Today we are going to discuss endometrial carcinoma. These summary points are very important for the exam point of view. So most common symptom for the endometrial carcinoma is postmenopausal bleeding. Remember this mnemonic for the history taking point of view: A, B, C, D, E, F and RMP. A for assess the severity, check for the anemia, check for the atrophy, check for the bladder bowel symptoms and dyspareunia. You have to remember this. Look for any bleeding disorders. Cervical polyp. Drug history is very important if the patient is taking HRT or tamoxifen. Look for any history of STI or PID. Ask family history of carcinoma. Radiation. Ask history for any previous masses, especially estrogen producing tumors. Ask history of prolapse, vaginal prolapse, cystocele, rectocele. Very important point to remember: if the patient is coming to you with the complaint of postmenopausal bleeding, in 90% of cases there is vaginal atrophy, and in 10% of cases there is endometrial CA. So always keep these two diagnoses on the top of your list, and other causes can be cervical, vulval, pre-malignant or malignant causes. Commonly, patient will present to you with the complaint of loss of appetite and weight and family history of CA or bladder bowel symptoms. Risk factors include obesity, diabetes, HRT, tamoxifen, PCOS, radiation, early menarche, nulliparity, late menopause, and Lynch syndrome. On examination, very important to do perispeculum examination and take pap smear, and do parietal examination to look for ascites and mass. The first line investigation is transvaginal ultrasound to look for endometrial thickening, endomyome junction, myome texture, adnexa, ascites, status of liver and ovary. Normal endometrial thickness for a postmenopausal woman is 4 to 5 millimeter. Endometrial biopsy. So the endometrial biopsy can be taken via pupil biopsy or diagnostic DNC or office hysteroscopy. But the gold standard is office hysteroscopy, because then you are having a direct visualization of the endometrium, and if you are suspecting any abnormal cells or if there is bulky or vascularized endometrium, then you can easily take the sample. MRI pelvis is done to look for the myometrial involvement and sentinel lymph node involvement and the metastasis of the tumor. So it is very important in diagnostic for the endometrial CA. Renal function test, liver function test, and chest X-ray. They are done to look for the metastasis, and they are important investigation in pre-op. So, 5-year survival rate for stage 1 it is 92%, stage 2 75%, stage 3 50%, and stage 4 15%. You can check the staging of the endometrial CA, FIGO 2023. I've shared the link at the end of the presentation. But we are going to discuss the stage-wise treatment of endometrial CA, which is very, very important from the exam point of view. In stage 1A, when there is myometrial involvement less than 50%, then the treatment of choice is hysterectomy. And in stage 1B, when the myometrial involvement is more than 50%, then the treatment of choice is hysterectomy. If high grade, then consider sentinel lymph node biopsy and adjuvant radiotherapy. And in stage 1C, staging laparotomy, that includes hysterectomy plus sentinel lymph node biopsy infracolecomnectomy and adjuvant radiotherapy. In stage 2A and B, radical hysterectomy, lymphadenectomy plus adjuvant radiotherapy. And in stage 2C, radical hysterectomy, lymphadenectomy, infracolecomnectomy and adjuvant radiotherapy. In stage 3A, neoadjuvant radiotherapy followed by radical hysterectomy or radical hysterectomy followed by adjuvant radiotherapy. In 3B, chemoradiation or surgery. In 3C, chemoradiation or surgery. And in stage 4, chemoradiation. So the drugs for the adjuvant therapy are cisplatin, doxorubicin and paclitaxel. Follow-up of recurrence: 3 months for 2 years, 6 months for 3 years, annually thereafter with oncologists with clinical history and examination. So this is the question which was repeated multiple times in FCPS exam, and it also came in February 2023. So the question was the class of chemotherapic agent that is most effective in the management of women who have recurrent endometrial CA. So the answer here is hormones. Here is the link on which you can check the FIGO 2023 guidelines, and I have also mentioned this in comments.